So thank you again for having me. Really thrilled. Just your northerly neighbor, just up the road. Perhaps a bit more cheese up in my area, but ultimately, Chicago is such a wonderful town, and it's great to be able to make this connection. So first of all, starting with my funding disclosures, the vast majority of my funding comes from the National Institutes on Aging, but I also receive funding from the National Institutes of Minority Health and Health Disparities, as well as the VA. So some objectives for our talk today. We're going to talk about the importance of aligning research towards real world action and the importance of not just asking a research question, but asking it in a way that leads to real world change. It's a hard thing to do, but we'll talk about how you can do that with different types of techniques. Certainly with this group, you all know this, but we will highlight the social determinants of health, including neighborhood disadvantage, and we'll talk about how these factors drive many of the health disparities that we see within any particular country and often reflect a society's legacy of structural inequity. And then finally, we're going to highlight the important role that open science and data democratization play in real world change and bridging that gap between research finding and action. So first of all, just to not spend too much time on the problem, but to give you an overview and the motivating core question that drives so much of our research forward. These are pictures from the United States, but they could be pictures from other places within the globe, certainly. And we know in most societies that we can improve health in places that look like this. If you live in a place that looks like this, you can have access to some of the best quality healthcare, to some of the most cutting edge medical technologies, and some of the best chances for high quality life outcomes as well as cures. However, regardless of the country you live in, if you live in a place that looks like this, your chance to be able to access such services and take advantage of such services is quite a bit different. If you live in a place that looks like this, you are more apt to die earlier of diseases, to have more diseases, and to ultimately have poor outcomes overall. So this is a fundamental issue within many societies, and we certainly see this in the field of brain health. So I am a geriatrician. My clinical practice is in Alzheimer's disease and memory disorders. And we know from many international studies, as well as studies within the United States, that brain health is not distributed equally. These issues of health disparities impact the brain just as they do other aspects of the human. So these are two studies from England, one from China, showing the strong linkage between poverty and increased dementia incidence. Additionally, we can look at data from the United States. This is data from the Kaiser Permanente system published by Maeda and colleagues that show individuals who self-identify as African American or American Indian and Alaska Native have a much higher dementia incident rate over the course of their lifetime as compared to other racial and ethnic groups. So ultimately the issue, and of course I could spend the entire talk on this fact that health is not equal, brain health is not equal, but ultimately in my field and certainly from my own personal interests in research, I am interested in solutions. I'm interested in not just describing the problem, but pushing research forward in such a way that it leads to changes in real world policy, real world intervention, and pharmacologics. And the NIH is interested in this as well. I could have pulled many, many, many different RFPs that touch on this issue. But if you look at most of the health disparities RFPs that are out there, RFAs that are out there from the NIH, you will see these words: eliminate health disparities. And that is ultimately the goal of a lot of this mechanistic health disparities research, is not just describing the problem, but moving us closer towards real world solutions by understanding underlying mechanisms and then tailoring interventions to address those mechanisms. So this is a field that's particularly important right now in terms of NIH health disparities research. And it's a field that you can certainly, hopefully, become interested in if you're not already engaged in thinking about funding towards the NIH. But the question is, how do we get to real world change? How do we get from knowing a problem exists to conducting research that helps us move forward? And we certainly think about this a lot in the field of implementation science, which is an area that I've been engaged in for a very long time. And the field of implementation science tells us about something called the translational chasm. And hopefully some of you have heard of this before, but it is the gulf between knowing something and ultimately resulting in real world change. It's the gulf between scientific discovery and actual changes in our world. And certainly earlier on in my career, as in many people's career, I think this is quite common in the early phases, there's this thought that I had, at least, that if I only just got the Science, the Cell publication, the New England Journal publication, and lots of media coverage of this important scientific finding that I'd have, there'd be some sort of magical occurrence that would occur, and then suddenly, boom, everything would change. There would be real world change, and this finding would change practice and be adopted writ large. But what we know is this is incredibly rare and often does not happen, because what is much more typical, even if it is a critically important finding published in a high-tier journal, is that these findings kind of roll down into the translational chasm. They sit on a bookshelf, they gather dust, and they don't ultimately translate to real-world change. People say, experts in the field say, wow, that's so important, we should be doing that. And yet the policy doesn't change, the practice doesn't change. And there may be confirmatory studies that all fall into that chasm as well. So we know the truth, we know the science is valid, but it does not ultimately translate towards real world change. So how do we get there? What is one answer? Well, one answer is to embrace some practices of implementation science that I'll be telling you about in a moment. And you do this before you even begin the experiment. These actions, this action of embracing these principles, happens before you conduct the study. It happens in the preparatory to research activities as well as study design. And before you even begin your study, you may choose different ways of finding your populations, of including different stakeholder voices, or choosing your variables that ultimately allow you to align towards action more successfully, building a bridge across the translational chasm and ultimately getting us towards real world change. Obviously, this is a vast simplification of how difficult this process is, but it's important to realize that the finding itself is not enough. You really need to think about what the change is ultimately going to be and align in that way. So whenever possible, I would argue we have an ethical principle as scientists to align our research towards action. It should be aligned towards treatments, interventions, and policy. And to do this, we must think about mechanisms, and we must embrace implementation science, regardless of whether we're a basic scientist, a clinical trialist, or a population or social scientist. So what does implementation science tell us? And again, this could be entire courses. I know at the University of Chicago, there's entire courses on implementation science, but just to give you a taste. So implementation science is the study of the barriers and methods to promoting the systematic application of research findings in practice, and especially in public policy. And a lot of the information I'm going to share with you today is really aligned towards clinical interventions as well as policy interventions. But some of these principles, if modified, could be applied towards the basic scientists and pharmacologic transitions as well. But thinking about clinical interventions and social interventions, first of all, our science has to be valid, but it also has to be conveyable. People need to understand the findings. They can't just be adopted by a narrow set of academics on an ivory tower in one corner of a field. It ultimately has to translate to a much broader audience, and it has to be accessible to that broader audience and ultimately feasible for that audience to potentially apply in its own domain. The work has to be end user focused in design. Even if something works, if no one likes it and no one's going to adopt it, it's not going to ultimately lead to real world change. It will lead to a paper, and perhaps an important paper, but get stuck in the translational chasm. It also needs to be generalizable. If you're only doing research with rich white participants, that is not generalizable. And ultimately, our research needs to be population representative in order to address the biggest issues that confront our society. When we think of individuals who are more apt to have those diseases, more apt to have those poor outcomes, they are not living in the rich neighborhoods around Chicago. They're living in the poorer neighborhoods more often. And so thinking about that in study design right from the start. Of course, the intervention has to be scalable and sustainable, and ideally targeted at a minimum intensity needed for change. So this idea of something very complicated is something that academics often like, and of course I'm generalizing in that, we tend to complicate things all the time. We have beautiful models and fancy math, and these things are beautiful and they're necessary. However, when we're talking about an intervention that's going to flow outside of academia, simplicity is a superpower. Simplicity and the ability to adapt to new settings is critically important and should be embraced whenever possible. And I think an excellent example of this comes from industry. When you look at the techniques and technologies that have really taken over our world, they could be used by a 2-year-old as well as any of us with PhDs. So thinking about that and thinking about the ability to design for a wide ranging audience is something that should be embraced. But of course, research needs to be valid, and we all know this. This is the core construct of what we do, this issue of internal validity. And in the field of health disparities, we are very interested in this. We are interested in what exactly drives health disparities. So moving beyond a description of the differences between 2 groups or 3 groups, and instead understanding why those differences occur. As I showed you, the NIH is very interested in this as well, and they've adopted a number of mechanistic health disparities frameworks. I'm seeing Megan nod. I'm sure she used this in her grant application. So this is one of the oldest frameworks. It was published in 2015 by Carl Hill and colleagues and adopted and is still adopted as the cornerstone framework for the National Institutes on Aging. Similar similar types of frameworks, these mechanistic multi-level frameworks, have been adopted by the National Institutes of Minority Health and Health Disparities and have disseminated throughout NIH. And what do these things say? Well, ultimately, just to simplify it, to take it down to its core principles, it says that health disparities come about because of a complicated interconnectivity between environmental, sociocultural, behavioral, and biological factors. Not just one of those, but all of those interacting across the life course from cradle to grave to produce wellness and disease. It is not a simplistic model. It does not just have one factor driving a particular health outcome. It recognizes that there are many factors driving health outcomes. And additionally, many of these items are external to the individual. And certainly in the field that I am in, these factors that are external to the individual are noted as the exposome, or the measure of all of the exposures of an individual over a lifetime and how these exposures relate to health. So certainly we often think of the individual and the individual biology, and precision medicine has been very good about this, about phenotyping us down to the very essence of our genetics. However, the individual, as we all know, lives within a context. It is interacted with a number of different forces, different types of exposures, things that vary from the microbiome all the way up to pollution exposure, chronic and toxic stress, systemic inequities, and so on and so forth. So this issue of exposomal study is moving forward very, very rapidly within the National Institutes of Health, the National Institutes on Aging, and is of increasing interest to many funders in understanding how social factors interconnect with fundamental biology to produce disease. The social determinants of health have a very prominent role within these mechanistic health disparities frameworks. You all know this definition. I'm sure you've seen it many times. The reason these factors are so important is that they are modifiable. And within any particular society that we look at across the globe, these are the factors that often are unequally distributed within any particular society. They can reflect a society's legacy of structural inequities. In the United States, for instance, the differential access to social determinants of health can reflect structural racism and other types of systemic inequities that decrease access to high quality schooling, good paying jobs, safe neighborhoods. And certainly when we think about the social determinants of health within these multi-level frameworks, we think of them at different levels. And of course, this group thinks about this all the time, but many of the audiences that I talk to don't think about social determinants in this way. So we can certainly think about them at the individual level, things like education, occupation, income. But you can also think about them at the contextual level, as you all very well know, things like the built environment, neighborhood disadvantage, and other toxic exposures. But some of the very big and very interesting questions, certainly for myself and my own group, is the importance of the environment in the setting of the individual. So if you have another way to say that is if you have an individual is otherwise equal, how would their health differ in a highly wealthy context as compared to a highly disadvantaged context? And certainly, hopefully you all have heard of the Moving to Opportunity study. This is something that comes out of your own institution. Critically important. It's a study of a natural experiment that occurred during the Clinton administration, in which the Department of Housing and Urban Development gave access to specialized Section 8 housing vouchers for families in 5 urban areas who could apply for a lottery to get one of these vouchers to move to a slightly less disadvantaged neighborhood. And of course, there's been thousands and thousands of papers published on this by the leaders at the University of Chicago who had followed these families forward and continue to follow them forward over time. Initially, there was thought that individual socioeconomics would change, that this policy would be a cure for poverty. But what they found is that there was no change. And of course, I'm simplifying so many of these findings here, so do forgive me for those of you who are experts in MTO. But when they looked at health, and surprisingly enough, it improved in many different aspects and in many different ways. So we had families that, although their individual socioeconomics did not change, their health did improve on many different markers, including mental health, cardiovascular health, diabetes. And this is one of hundreds and hundreds and hundreds of examples that I could show you, showing the independent impact of context over and above the individual level factors. And we see this again and again and again and again. So context itself has an impact. The exposome itself seems to have a strong association. We're still learning more about that, but certainly not all of the impact is just at the individual level. Certainly this becomes,
could I actually interrupt on that last slide? Just a really quick focus question about that. Can you comment on how quickly those things are likely to change? For example, health, reducing stress or stopping smoking even for like a few weeks or something could really improve health in a short time. Socioeconomic status issues might be generations in of low education, low working jobs or opportunities. Were the lack of change by moving people into new environment, was that over short periods of time or years and years and years and years?
So the initial measures that I showed you were over the course of about 10 to 20 years, or slightly less, 10 to 15 years. But what was found is that the second generation of these families that moved were emerging from poverty. So not the parents, but the children. And of course, vastly generalizing here, but if you go back, and of course, this will all be in the recordings, take a look at Ludwig's papers out of Science, New England Journal. They were all published kind of in the early 2010s. So almost a decade, or it is a decade, look at COVID messes with my time, a decade ago now. But take a look at these papers because they are landmark papers of the importance of context over and above the individual level factors. This becomes so important because so many of our interventions target the individual, don't they? They tend to target behavior change in a particular individual without thinking about these exposomal factors that could also be playing a key role. And certainly our interest at the contextual level also is driven by the fact that many of these contextual level measures reflect systematic inequities within a particular society, as I had mentioned before. This is an example from the United States. And this is a map, hopefully all of you know about this construct. This is a map of redlining areas. This happened to be in Philadelphia. The map, I believe, comes from the 1930s. And what you're seeing here are the red areas are areas denoted as hazardous. This was a map created by a banking organization, by a financial lending organization. And for families who lived in these red areas, they were more often denied or had no access to home equity loans, loans to start businesses, loans to reinvest in their community because of this hazardous designation. Now, if you lived in one of these blue areas, note best, do you see it on the chart or on the legend here? You had good access to these types of monies in order to invest in your community and invest in the infrastructure around you. Now, the neighborhoods that were more often in the red tended to be African American neighborhoods, Black neighborhoods from these times. And this lack of investment, this perpetual inequity, we see this echoed through to today within the markers of disadvantage that we can measure at the neighborhood level. So this action may have occurred some time ago. Some types of redlining still occur to even this day, but the legacy of that political policy action continues on into our current era. And we can see this through metrics of neighborhood disadvantage. So we spend a lot of time thinking about these metrics. Places in Europe and other places outside of the US have thought about them much, much longer than we have. But these metrics, there's an entire field of them. They come out of the world of health policy and economics. They are multi-domain metrics of disadvantage that tend to be used for policy purposes in order to target resources and to think about adjustments and things like payments and other types of eligibility. They tend to use measures of the social determinants of health in a very discrete geographic area, typically between 500 and 1,500 persons, population-based. And they're a cornerstone of health policy decision-making in most places other than the United States. The first of these was developed in 1983 by Sir Brian Jarman. He was the president of the British Medical Society at that time, and he was having difficulty recruiting physicians or GPs into highly disadvantaged areas of the UK. So he built one of these indices based on those classic social determinants of health and identified on these maps, they happen to be areas of England. Bradford is one of the areas, if you know that area, the York area. The Black areas were most disadvantaged, the white were the least on these maps. This comes from his original landmark BMJ publication. And he was able to take these metrics and convince the Thatcher administration, Margaret Thatcher, to change the way they paid physicians, to recruit more physicians into these highly disadvantaged areas within the UK. It worked splendidly. They paid them more, they got more physicians in those areas and were able to target their resources to the areas of need more effectively. Since that time, these types of metrics have been used widely across Europe in particular. So, and not just within single payer healthcare systems or nationalized healthcare systems. Places as diverse as Germany, which has an insurance-based system quite a lot like ours, as well as many other places, New Zealand, Sweden, Canada, you name it, they have these types of multi-domain indices, and they use them for the purposes of efficient resource allocation. So they have not traditionally been used in the United States, and we have been interested for a very long time in convincing the US that this is something important for us to think about. So this brings us back to some of these constructs of implementation science. And when we think about designing a project or designing a research question that is actionable, one of the areas of action is in policy. And so when we think about policy actionable metrics, if you were to bring someone in from the Centers for Medicare and Medicaid Services and ask them what would be needed in order to ensure something was actionable, they would say many things, but likely they would say these things for sure. So first of all, a policy actionable metric really needs to be inclusive of all of the persons within a particular policy unit. Within the United States, this could be a county, it could be a state, or it could be the full nation. But ultimately, if you can't get these metrics on nearly everyone, it's difficult to apply a policy uniformly. Additionally, the metrics have to be valid, right? They have to kind of pass that validity test. They have to be regularly updated. They have to be rigorously tested, and they have to be accessible. So these cannot be metrics that are hidden in some way. You can imagine trying to pass new policy guidelines or laws on a metric that no one could see and no one could access. The public would be up in arms. So they have to be accessible and they have to be understandable by a wide swath of society, not just academics or researchers. And then ultimately constructed to meet the needs of a range of possible users. Again, getting us outside of academia is critical here. So we were interested in doing this for the US, as I mentioned, and we spent a long time, almost 15 years ago, thinking about potential metrics that could be available for the US that could be translated into policy actions similar to those that have been used in Europe for decades. And we thought long and hard about whether we wanted to develop something new, but we decided actually to go with something that had already been developed but needed quite a bit of refinement. So we started working with the Area Deprivation Index, which was created in the late 80s and early 90s by the Health Resources and Services Administration, but it wasn't ready for policy prime time because it was not fully aligned with those European indices in a number of important ways. But it did include different metrics of education, employment, housing quality, and poverty. Its data source was old though and no longer available, so that needed update as well. So we received an R01 from the National Institute of Minority Health and Health Disparities to update this metric and to validate it with partners across the United States. And this took us a really long time. The metric had to be refined down from the county level to the census block group level. I don't have to tell this audience what those mean, and ultimately validate it to ensure that the new data source that we were pulling from, in this case, the ACS, many of the particular variables that were pulled in the different factors looked a lot different than old long form census. So that the missingness rates were different. There were just a lot of statistical considerations in the validation and construction of this. So it sounds easy, but let me tell you, this slide, it represents like 7 years of work. So I spend a lot of time with different groups that don't have an understanding of demography like this group does, but you will understand this quite well. So on this map is Milwaukee County. The whole entirety of the map is Milwaukee. And Milwaukee County and many of the county health rankings and other types of metrics is noted as one of the most disadvantaged counties within the state of Wisconsin. And certainly if I were to show you this on a county map, the whole county would be red or the most disadvantaged in the heat map format. Now in this map though, these are census block groups denoted by ADI, ranked by ADI at the state level. And what we see is the red areas are the most disadvantaged and the blue are the least. And not surprising to this group, as I'm sure you know, it's the inner city core of Milwaukee that's the most disadvantaged, most highly disadvantaged. And it's surrounded by a ring of some of the richest neighborhoods within the state of Wisconsin, this extreme blue, especially along that lakeshore. You can imagine the mansions. So we are interested not only in targeting policy and interventions and resources effectively, but as I'll show you in a moment, we are also interested in linking these metrics to fundamental biology. And this level of measurement precision becomes absolutely essential when we start talking about differences in biology and understanding how these exposomal factors influence life course outcomes in a particular individual. So this level of geography is critical for us and has made this metric much more policy actionable. When we use this metric to characterize neighborhoods across the full United States, what we can say is that the most highly disadvantaged neighborhoods are often in urban core areas like you saw in Milwaukee. This is something that we see across the US, but they're also in highly rural areas, especially in Native American communities. And you may be able to see some of this on this map. Of course, as you know, the rural census block groups are just geographically larger because of the population sensitivity than the urban. So the eye is drawn to those here. We can also say that the racial makeup looks different within these particular neighborhoods. And this data is drawn from 100% Medicare sample. So all Medicare patients within the United States are included here. But of course, Medicare is primarily an insurance program for older adults. So this does not, these percentages here are not representative of those outside of Medicare. But what we can say for these older adults is that those who lived in the least disadvantaged neighborhoods, about 90% self-identify as white, 8% as Black, and you see the other racial categories there. In comparison, in the most disadvantaged neighborhoods, about 58% identify as white, 32% as Black, and other racial categories. So there are differences in those makeups. When you think about using the ADI in research, it's important to remember a few things. The first is, and again, I don't need to tell this group this too much, but this is something that comes through certainly with other research groups quite a bit, is that this construct of individual level SES and contextual level SES are not equal. So they can certainly be correlated, but they should be treated as equal and independent parameters within a model as you go forward and as you interpret as well, critically important. An individual who lives in a highly disadvantaged neighborhood should not be labeled as a disadvantaged individual. They should be labeled as an individual who lives in a highly disadvantaged neighborhood, if that makes sense. Also, the associations with health outcomes tend to be nonlinear. So they tend to be more strongly associated at the tails of the distribution. A great example of this is in some of the resource utilization work that's been done. You see these massive exponential kind of J curves in those most disadvantaged neighborhoods where the slope becomes asymptotic. So not only is it not linear, but it seems to be exponential in some cases. So if you use this metric within your research, be sure to check for nonlinearity, and I'm sure you can work with your biostatisticians. I won't go into all the steps for that. And then finally, remembering that when you apply these metrics, don't forget about the fact that many of these metrics reflect systematic inequities and structural racism within our society. So the application and interpretation of these metrics must be informed by health disparities theory. So our group is very, very interested not only in producing these metrics, we've been doing that for a long time, but for those of you that joined in the beginning, you'll know that I'm an Alzheimer's doc. I'm a geriatrician, I'm a memory doctor. So we spend a lot of time thinking about the Alzheimer's space. We think about brain health, and we think about timing and dosage of exposure of these factors across the life course and how they influence brain structure and brain function. And we do this in a number of different ways. I'll give you some examples of some of the studies that are ongoing, but fundamentally in all of these studies, we embrace something called social biological phenotyping, in which we're thinking not just of the social factors, but also quite interested in the biological factors and really trying to build those bridges between our basic scientists and our social scientists towards producing new knowledge. So this study was one of 951 cognitively unimpaired, so these are people with no diagnosis, cognitively unimpaired research participants who have been in a cohort study at the University of Wisconsin for over a decade. Looking at brain health. But they're normal. They don't have any diagnoses, but they are exquisitely phenotyped in terms of their brains. They've had many MRIs, they've had many cognitive tests, really to understand more about how they are aging across their life course. And we first looked cross-sectionally at their residential address, geocoded that and linked to neighborhood disadvantage by ADI. And what we found was published in JAMA Neurology in 2020 was that those individuals who are living in the most disadvantaged contexts had lower total brain tissue volume and lower total hippocampal volume as compared to their counterparts who are in the less disadvantaged neighborhoods. Now, these findings, I'm just showing you the overall findings here, but they stood up even after adjustment. And what was particularly interesting is in the mediation models that were published as a part of this paper, the total brain tissue volume, those differences were mediated almost exclusively by cardiovascular risk factors. So what a fascinating finding. This, and of course, we all know this, right? We know hypertension, diabetes, obesity, cardiovascular disease is not as well controlled within disadvantaged populations or within disadvantaged areas, but an active area of target, an active modifiable risk factor, and perhaps something for additional focus. However, when we looked at the mediation models around the hippocampal volume, cardiovascular risk factors did not play a role. And this speaks very interestingly to some of the early life developmental work and links to some of the early life developmental work that have been seen both in animal models as well as in children around hippocampal volume development. Individuals and different studies suggest that different model animals as well as humans who are living in highly disadvantaged contexts have differential development of their brain structures within those early years. And certainly we can say in the mouse models, when they're in an enriched context as compared to a deprived context, their hippocampi look very, very different. So this may be pointing to different types of physiological phenomena. Additionally, what does this look like longitudinally? So when we looked at the same cohort and we compared these individuals to themselves, so not to overall to the whole group, but to themselves, so where they entered and where they were at the point of this particular study, we found some startling differences. So those individuals who are living in these highly disadvantaged contexts, as compared to themselves, they had more accelerated degeneration, specifically cortical thinning, in their Alzheimer's affected regions of their brain. And this was associated with greater cognitive decline. Remember, these are individuals who don't have dementia, they don't have a diagnosis, but their brains are shrinking and they're losing those subtle cognitive abilities. And it seems to be highly associated with where they're living. And likely, of course, other mechanisms are going on there and need to be unpacked, but very concerning nonetheless.
Dr. Kind, we have a question in the chat from Dr. Louise Hockley about the last two slides. I thought I might
Sure.
pause.
Oh, sure.
Do you want to ask your question, Louise? I don't want to.
Sure. I was just curious. I mean, usually in these disadvantaged neighborhoods, I may be wrong, you can correct me, but there isn't much mobility. These are people who've probably lived in these same neighborhoods for a long period of time. But I was just curious whether you knew anything about their history. What if there's a critical period and their exposure to this disadvantage is actually stemming from something that happened years ago and they're just now reaping the costs?
That is an excellent question, and I would beg you to stay tuned for a few more slides because we're going to get there.
Okay.
But it's an excellent question because this is one we asked ourselves, to be honest with you, Louise. It was exactly where we went as well with our mind. So let me get there, and I think you'll be pretty excited as to what's coming down the pike. So this is on our way to getting there, I promise. So the next step, for those of you that are aware of the Alzheimer's field, you may know that the gold standard diagnosis is still neuropathology. It's still tissue. And so but many of these tissue biorepositories are not socially characterized. I don't know if any of you have ever worked with a tissue biorepository, or especially these tissue biorepositories that have been around for a long, long, long time. And some of them go back many, many decades. So we were interested actually in seeing whether it'd be feasible to link these social factors to tissue, to existing tissue that had been exquisitely phenotyped already, genetics, genomics, every omics you can think of. And yet many times we didn't know any fundamental social factors about these individuals whatsoever. And unfortunately, that's the story of many biorepositories across the United States. So we partnered with the University of California, San Diego in our own brain bank to look at 450 decedents, 53 decedents who donated their brains between 1993 and 2016. The reason we didn't go beyond 1993, San Diego did go earlier than that, but everything was on yellow lined paper and it was just a bit too much of a lift to get all that data. So we stuck with the electronic files. But they were not socially characterized. These were individuals that the tissue was beautifully characterized, but really there's no social factors. So we were able to get their address from their autopsy report and from the condolence letters that were sent to the family. And we used that as a starting point, first of all, to cross-sectionally geocode and understand what the time concordant ADI exposure was at the time of death. So we can build these ADIs back as far as we like. And, but this is what we did in this case. And this was published, as you can see, in JAMA Open. First, we were able to say it was feasible. We could do this, which was really our goal. It was fascinating how well we could do it. It was really opened up a door to an entirely new area of inquiry. And what we were able to say with this particular cohort is that living in the most disadvantaged neighborhood decile was associated with an increased odds of AD neuropathology. So not only are we seeing the brain shrinkage, the hippocampal volume differences, and the cognitive differences, as well as increased accelerated neurodegeneration, but we're seeing the amyloid plaques and tangles associated, the fundamental biology associated with these areas. Now getting to Louise's question, because these are the questions we asked ourselves and what she just asked as well. Well, what about longitudinality? What about dosage and timing? That's exactly what we asked, and that's where we're going. So we received a grant from the National Institutes on Aging to be able to characterize the life course of these individuals. And we've been doing this both with decedents, and I'll tell you how we do that as well as with living participants. So the living participants, pretty straightforward. We use survey techniques and residential history construction, and we can go into that if you'd like. But with the decedents, we've partnered with our historical colleagues and our archivists and have used bread and butter genealogical and archival tracing methodologies to take this individual at the point of death and to trace them back to their point of birth. And doing this, we are able to find 73% of all their person years. It's fascinating how much is in existence in the public record. And each of those documents, so military enrollment sheets, the US Census prior to 1950, of course, at individual level, marriage certificates, land purchase certificates, all of these things are in the public domain. Each and every one of them has an address. So you can pull the address from each of these items. And at least within our preliminary studies, we've been able to build these geospatial frameworks backward in time to the point of birth to understand about, to build the frameworks as a first step, to understand about dosage and timing of exposure to any sort of exposure that could be geolinked. So this has been very exciting to the National Institutes of Health, as you might wonder. And so we were invited to come in for a multi-site study, which was just funded this last year. And this is a 22 site, just shy of $30 million R01, which we are leading. It's a national consortium called the Neighborhood Study, in which we are building these geospatial frameworks for just shy of 10,000 ADRC brain bank decedents to understand more about the dosage and timing of these exposures for these individuals who have already donated their brains to science. Again, these tissues are typically very well characterized already, as well as living participants that are affiliated with our Alzheimer's Disease Research Centers network. And you can see the little red stars here where the different centers are. We have pretty good national representation, at least for where the centers are. We have some new groups that hopefully will be joining us soon from Texas, which we're looking forward to that as well. But certainly we've been sharing these metrics broad and wide, and we can say now certainly hundreds and hundreds of groups are using ADI to look at a whole host of things, including epigenetic age acceleration. We've seen a higher risk of postoperative delirium for individuals who live in a highly disadvantaged neighborhood out of some work out of Harvard, later dementia diagnosis and difficulty accessing care and social services. In an important study out of Yale, they showed not only do individuals who live in these contexts have decreased life expectancy, but they need help. They lose the ability to take care of themselves earlier in their lives. It's a very patient-centered focus of decreased active life expectancy. They're in nursing homes much longer, which is certainly, as a geriatrician, that's certainly heart-wrenching. We can also say that the inclusion in studies, with many of the studies that we've helped, geocode looks almost always like this histogram. It almost doesn't matter the study. There's an overrepresentation of individuals who live in wealthy contexts and an underrepresentation of individuals who live in highly disadvantaged contexts. And so we have been in many discussions with the National Institutes on Aging in particular about, really calling for these types of neighborhood metrics, not necessarily the ADI, it could be other things, but some sort of metric collected as a standard demographic characteristic of all persons coming into a clinical trial or a cohort study. Certainly, we also need research on best practices for recruitment and retention of individuals who live in these highly disadvantaged contexts. So it's a lot harder to, take part in research. So coming back to this idea of policy actionability again, just to remind you of these two pieces. So they do need to be actionable and they need to be constructed to meet the range of a whole variety of end users. If all I am able to do is reach people in academia, it's not enough to lead to policy change. And so we really have been adopting and embracing open science principles, and particularly the type of open science that's called data democratization. So not only do we make the scientific parameters available to anyone within the research audience, but we're doing our best to try to make them accessible to anyone regardless of their education. So our goal is, if you can use a smartphone mapping app, you can use these metrics, and that's what we're trying to do and have been trying to do. So in 2018, with a New England Journal article, we launched the Neighborhood Atlas, and this is a free online data democratization platform that took over 2 years of development to try to make it as simple. Remember that simplicity is a superpower, to try to make it as simple and understandable to not necessarily to researchers. You all are so smart, you can figure things out very easily, but to groups that don't have a research background. And What we found is that it's been very popular. It allows for customized mapping interface, so anyone kind of like Google Maps. It's free, it's open to anyone. At this point, we've had nearly 500,000 views and we're having about 1,000 downloads a week. About 50% of our downloads are outside of the academic sphere. They're going to industry, government, health systems, community groups. And this is kind of what the atlas looks like. You can pick any state you want. I threw a screenshot of Illinois on there for you. But of course, you can look at any place within the country. It uses these heat maps where red is most disadvantaged, blue is least. Oops, wrong way. And you can zoom in with landmarks. The landmarks are particularly helpful for our community-based groups who are interested in using this for resource targeting, using it for outreach and different types of direct service delivery, which has been done quite a bit. So we've had thousands of groups, as I mentioned, thousands and thousands, nearing 100,000 download the metrics. You can see some of the range of topics that are covered here, everything from cardiac outcomes to liver transplant to pediatric outcomes, brain connectivity, the list goes on and on and on. But certainly I have to say, I could have never done this. Our team would have never been able to do all this. So it's great to see others take these metrics to the next level. The NIH has been promoting this very, very strongly, particularly the National Institutes on Aging, which is the main funder now of the Neighborhood Atlas. ADIs from the Atlas are being embedded in many core resources, including, and have been probably for the longest, in the ABCD study, which is a study of childhood brain health and brain development. It's being studied, we're helping the NIA SEER team to embed it as part of the Medicare data that they provide to many of the cancer centers across the country, as well as many different clinical trial groups and cohort studies. I mentioned the clinical trials reporting. We're working, CMS and CMMI have been using these metrics to think about payment adjustment, harkening back to the old policy uses of these metrics. There are some models that are going forward with that, which is very exciting. Many professional medical societies have adopted these now. Most recently, the Society for Thoracic Surgeons are using this in their performance evaluation and thinking about how differential performance might happen. And then we've had lots and lots of industry interest as well. And our industry partners tend to fall into two categories. One is using the metrics to, shine new light on the data that they already have. The other is to use the metrics to design specifically for these low resource areas to try to improve health in new ways and to inform technology design in particular that is sensitive to all of those issues that arise within a low resource setting. During COVID, it's been very, very popular in the last 2 years. And this is where I'm just so pleased to see so many translations to real world policy. So the metrics on the Atlas have been leveraged by a number of state and federal policy groups during the COVID pandemic. You all probably are well aware of the SVI and some of the other metrics that have been leveraged. Lots of reasons why a different state might choose ADI, but many of them have. Usually it's for a whole host of reasons. But just some examples. Pennsylvania was the first. Doug White led the charge here. He's a critical care bioethicist. And in March of 2020, he quickly realized that they needed some sort of a fair allocation algorithm if they were to run out of ventilators, run out of remdesivir, run out of medical therapies. And so he proposed an algorithm that would mitigate health disparities through inclusion of the ADI. So if individuals lived in these highly disadvantaged contexts, they would have a better chance for getting a ventilator, better chance for getting remdesivir. And this was ultimately adopted by the state of Pennsylvania, as well as a number of different health systems as part of their ethical allocation frameworks during surge. Additionally, COVID vaccine resource targeting has been, obviously there's been a number of geoparameters that have been used in targeting these. ADI has been used in a number of states. Alaska is one example. And we've been working with Maryland for over a decade in their efficient alignment of resources to needs across their health system. They have a waiver program with CMS in which they are able to set the rates for private insurance, Medicare and Medicaid, all within a centralized system. And they've been using these metrics to try to understand differential performance between Baltimore hospitals and other areas, hospitals that have different capture of disadvantage, and thinking about innovative payment approaches in order to motivate better health overall. So this work has ended up with us launching the Center for Health Disparities Research at the University of Wisconsin. We're very excited about this. And the goal of this center really is to link cells to community, to really push forward some of these social biological phenotyping techniques that I just shared with you. So taking these wonderful approaches from social science, but applying them to tissues and to bring in our basic scientists to help us understand more about the fundamental mechanisms that could be ongoing, leading to the differences in health that we see. So we are working very, very hard to build community, to increase our education pipeline. And the other women that you see on this slide are the directors that joined me with the leadership team here. So in conclusion, I know we're running out of time here. Hopefully I've convinced you that whenever possible, you should be thinking about aligning your research towards action, because that's really the whole point of research. It should be a lever towards real world change. And so think about that right from the point of study design. Social determinants of health reflect a society's legacy of inequity. This is true in the United States, true in Russia, true in Afghanistan. You look at any society across the globe, and differential access to social determinants are ultimately reflections of a whole host of political factors and systemic inequity factors. So remember that if you decide to study these, because they're critically important. Certainly, we've been arguing that neighborhood metrics should be collected as a part of research protocols and certainly clinical trials enrollment to ensure population representativeness. And then finally, the importance of open science and data democratization. If we hadn't launched the Atlas, as I said, I'm an Alzheimer's researcher, but if we hadn't launched the Atlas, this additional use would never have been realized, the additional impact during COVID and the additional policy uses that have since gone forward. So this work wouldn't be possible without a whole range of people and lots of funding, and certainly our wonderful research participants that donate so much of their time and themselves every single day. So I'll stop there.